Hello, ladies and gentlemen, greetings. I am Dr. C.N. Srinivas, Director of the Laboratory Medicine, Miyat Hospitals, Chennai, India. So, we will take first the nephritic syndrome. Here we have 58-year-old woman who presented with fever, has lower limb swelling with a reduced urine output. She is having comorbidities, she has hypothyroidism, but she is not a diabetic, not a hypertensive lady, and does not have any previous medical illness itself. Blood showed elevated C-reactive protein with normal ASO titers, that is anti-streptolysin O titers, usually done for the nephro patients to understand whether they have got streptococcal infections. Urea is elevated, it's 73 milligram per deciliter, normal being 40. Creatinine is also elevated where it is 2.7 milligram per deciliter, normal being 1.2 milligram per deciliter. Note this, she had history of cellulitis of the lower limbs 4 weeks back. So, with this information what we have got, we can think that her kidney is having a damage, but let us see what type of damage she has got from the urine analysis. Urine analysis beautifully shows a nephritic look. I told you in the beginning, when you have got increased hematuria towards the nephritic syndromes itself, the blood chemistries on the urine shows high, that's 3+, has got a mild proteinuria here. Leukocytes, because of the mixing of the blood, you have got now the RBCs have got 4000, and you have got additional renal tubular epithelial cells. You also have got some pathological casts, hyaline casts, which are also being flagged off here. So, let us see the histogram. So, this is the scatter plot which shows the red color, red blood cells. This is scatter plot. Now, if you see the histogram, you have a mixed RBCs, but predominantly you see that they are dysmorphic RBCs. So, you have got more amount of dysmorphic RBCs, but you also have a spike in isomorphic. You can call this as mixed, but I would label this as more towards the dysmorphic RBCs itself. So, when you are looking in the urine analysis UD images, you have beautiful pictures of the dysmorphic RBCs here in the class 2 mixed with that of the isomorphic RBCs. You have got in class 6 the distribution of the RBC cast, a higher part of an RBC cast for you people, and you see this, you have got a beautiful illustration of all the three. You have got his scatter plot showing RBCs, you have this, and you have got the epithelial cells or the renal tubular epithelial cells itself. So, now let us see how dysmorphic RBCs can be displayed in our UD itself. So, in UD these are the various varieties of the dysmorphic images we got in this case. So, you have got dissolution of the RBC membrane, then rupturing of the membrane over here, then these are blips what you can see, which is called as the Mickey Mouse cells. This is one more Mickey Mouse cells, you have one more Mickey Mouse cells. So, you have got more than 6 to 8 types of dysmorphic RBCs, which are beautifully picturized by the UD analyzer from Sysmax, which is very good to be stored even for the clinicians to come and have a look at these. So, let us see what is happening to that of the renal biopsy. Oh, good. So, the renal biopsy shows beautiful 2 coats of the soft tissue what has been given, and look at these glomeruli. The glomeruli are very plump, they are glomerulomegalic, has got increased activity in all this glomeruli. Let us go to the high part. So, when you see the high part of the glomeruli shows necrosis, has got hypercellularity because of neutrophilic infiltrate, and it is quite busy. So, presence of more than 3 neutrophils in the glomeruli indicates that there is a glomerulonephritis. Associated we have got necrosis. Let us see the tubules. The tubule shows there is some damage to the tubular epithelial cells, exfoliation of the renal tubular epithelial cells here with that of the leukocytes indicates that there is a minor injury even to the renal tubules itself. So, this is a case where you have got a nephritic syndrome group of urinary profile, and you have got a kidney biopsy of the same showing in necrosis, neutrophils, and it says that there is a glomerulonephritis of the glomeruli over there. So, let us see the immunofluorescence here. Beautiful focal segmental dense granular staining of the mesangium and the basement membrane by 2 complement systems. that is the C3 complement and the C1Q complement itself. So whenever you have got glomerulitis infiltrated by the neutrophils, you have got nephritic syndrome. It's a non-ASO titer. The ASO titers are normal, but your C-reactive proteins are very high. Deposition of complements C3 and C1Q indicates that it's an immune complex based disease, and hence we have to review in entirety the urine analysis and the renal biopsy together. So the urine analysis shows dysmorphic RBCs predominantly. You have dimorphic picture, though you have got moderate proteinuria. Presence of red cell cast, granular cast indicates that it's a nephrotic profile. Renal biopsy shows hypercellularity with necrosis of the glomeruli. Immune complex deposition of C3, C1Q concludes that it's an infection related glomerulonephritis. So the diagnosis of the infection related glomerulonephritis can be obtained even before I could get on to that of the kidney biopsies, and prepare myself to interpret these slides along with the nephrologist to make sure that we give the value for the urine analysis itself.